arterial course is an indication for treatment. We see anomalous rights more commonly. We see them in older patients, patients that are asymptomatic. And generally, the cardiovascular surgeons will want to prove that this anomaly is actually causing symptoms. They'll want like some sort of stress study to prove that there's ischemia in that RCA distribution before they will operate on it. And you can do that. I think stress MRI may be the best test according to some studies, but a lot of times it'll be just assessed-MIBI or stress echo, those kind of things to prove that there's stress-induced wall motion abnormalities or perfusion deficits in that right coronary artery distribution. And also if the right coronary artery is non-dominant, if they have a left dominant circulation, most of the time they won't treat it. I'm sorry, was there, oh, here's a chat question. Oh, yeah. That's correct. It is an anomalous origin of the RCA. And so still, though, if you see an anomalous right, you want to report it. They need to be worked up. A lot of times they will opt not to treat it, but sometimes they do. And if they are having symptoms or ischemia in that distribution, then they will unroof an anomalous right. And so here you can see the coronals. We have our nice central dot sign. You can see how it's oval shaped, where it's running within the wall. And then when it comes out of the wall, when it's in the epicardial coronary fat, it's just more nice and round. And sometimes it's hard to tell with CT. I mean, we never can tell for sure if it's intramural because we don't see the wall. We kind of infer from the shape. They can do IVUS, intravascular ultrasound, in the ER to determine where exactly the intramural part is and if it goes far enough to unroof. All right, so anomalous rights, they arise from the left cusp, typically with an interarterial proximal course. They're 3 times more common than anomalous lefts. There's a weaker association with sudden cardiac death. It can occur, but a lot of times it doesn't. It's more controversial. Many surgeons will want to prove ischemia related to the anomaly prior to actually doing a surgery to fix it. All right, here is the next case.
Yes, sir.
And this was a fairly young female with a abnormal. Sure.
So can you start recording from your end because the internet connection is unstable here to start recording?
So do I want to, you want me to start recording?
Yes, sir.
Okay, let me see if I can do that. Is that under more? So record to the cloud.
Yeah. Record to the cloud or the
recording in progress.
I think I did it.
Thank you, sir. Yes, okay. You can continue. Sorry to interrupt.
Oh, no worries. So this was a young patient with an abnormal echo. And I will just show you the images and y'all can think about what it could be. This is one of my favorite cases. And we'll scroll back up. So the first thing that kind of jumps out at you are the size of the coronary arteries. Yeah, we have some answers in the chat that are correct. So these coronary arteries are huge, and these aren't focal aneurysms like you would see in Kawasaki's disease. These are diffusely ectatic dilated coronary arteries. And there's only two things that'll give you coronary arteries this big. You can get ectasia with connective tissue diseases, Marfan's, those kind of things, but they won't be this ectatic. So when you see these severely dilated, diffusely ectatic coronary arteries, the first thing you want to do is look at the origin. So here we know this is our right coronary artery. This is the artery in the right atrioventricular groove. We can follow that up. And there's my mouse. And you can see it's coming off appropriately from the right coronary cusp. We can go to the left coronary artery. Here's the artery in the left. This is the artery in the anterior interventricular groove. So this is the LAD. We follow it up. And you can see it's got this connection to the main pulmonary artery. And there's a lot of tortuous vessels here, but there is no vessel coming off of the left coronary cusp. So not a fistula, but this is actually ALCAPA, or Bland-White-Garland syndrome. So ALCAPA, anomalous left coronary artery arising from the pulmonary artery. It's an acronym. Bland-White-Garland is the eponym of the physicians that described it. And so when you have an anomalous origin of the coronary artery from the pulmonary artery, you get diffuse coronary ectasia. And these, especially ALCAPA, is associated, it's a malignant anomaly associated with sudden cardiac death in young patients. They tend to present in infancy or childhood with heart failure, massive MI, those kind of things. And the interesting physiology, and when I asked the residents, I was like, why is it a malignant anomaly? The residents will usually say that, well, because it's blue blood going into the coronary arteries, the pulmonary artery blood is deoxygenated. And that's really not the problem. If that was the only problem, if it was the blue blood going into the coronary circulation, it would be tolerated pretty well because the coronary extraction of oxygen is much higher than other organs. And so if you look at like the oxygen saturation in the coronary sinus, it's much, much lower than mixed venous oxygen saturation, which is, around 70%. It's closer to 20%. So it could get a lot of oxygen even out of the mixed venous blood that's coming into the pulmonary artery. But the problem is in the pressure differential. And so you'll see, and this is a really nice case because you actually see the jet of contrast here. So the blood doesn't flow from the pulmonary artery into the coronary artery. The blood flows from the coronary artery into the pulmonary artery. So this left coronary artery is not getting blood from the PA, it's dumping blood into the PA. So it's the steal phenomenon. And so for this person, the right coronary artery has to supply the entire myocardial oxygen demand, and there's epicardial coronary collaterals. So it's supplying blood to the left coronary artery, which is dumping it into the pulmonary artery. So you have only the right coronary artery that's got forward flowing blood to supply the heart. And so it's the steal phenomenon, this pressure differential between the 120/80 versus the lower pressures in the pulmonary artery that causes it to be such a severe anomaly. And typically the treatment for these will be reimplantation. You can ligate the coronary artery and stop the steal, and that may be sufficient in older patients, but they will usually reimplant them because they're young patients. All right, well, some people in the chat said ARCAPA. That was actually ALCAPA, but they're kind of similar. Let me get the chat off. All right, so this is ALCAPA. Large left coronary artery collaterals, right coronary artery with the left to right shunt. The steal phenomenon is kind of the buzzword you want to remember, and it presents usually early in infancy with heart failure. This was a little older patient than we typically see ALCAPA in. There is also ARCAPA, which is where the right coronary artery arises from the pulmonary artery, and that's an example we have here. Here's the PA. This doesn't have that nice jet that the ALCAPA case did, but you can see here the right coronary artery is not coming from the right cusp, but we still see those same dilated, severely dilated coronary arteries. So when you see that, there's two things it can be. First thing you do is go to look for the origin, see if one's coming off the pulmonary artery, and because all the coronary arteries will dilate if you've got ALCAPA or ARCAPA. If the origins are normal, then you look for a fistula. You've got the only other thing that'll give you diffuse ectatic coronary arteries will be a fistula to a low pressure chamber or vessel. So ALCAPA, less commonly symptomatic, can occur in older patients. They tend to present later. They will fix ALCAPA though. They will reimplant it. So both ALCAPA and ALCAPA are malignant coronary anomalies that would need referral to cardiology or CV surgery. And here's an example just of a fistula. This is a fistula to the right ventricle. These are images from the internet, but you can see this huge dilated right coronary artery dumping into a low pressure chamber, the right ventricle. Generally with fistulas, the fistulous vessel dilates a lot. The other vessels tend not to. And here you can see part of the left coronary artery, which is pretty normal in size. Here's another example of a fistula. This is to the coronary sinus, and we frequently see them to low pressure chambers of the coronary sinus. So coronary artery fistulas, you can have coronary cameral fistulas, fistulas to a chamber. You can have AV fistulas, fistulas to the pulmonary artery or coronary sinus or its tributaries. These are usually congenital. Sometimes they can occur iatrogenically after biopsy or trauma. There'll be a large tortuous vessel connecting a high pressure system with a low pressure system, typically PA, RA, RV, or tricuspid annulus, great cardiac vein, or coronary sinus. If the fistula is small, it's usually not a big deal. If the fistulas are big, they can cause arrhythmias, dyspnea, congestive heart failure, and can cause cardiac murmurs, loud, superficial, continuous murmurs. There's a grading or descriptive table for these fistulas, but we don't typically use it. And here's just an example of a small, like kind of borderline fistula that they were going to treat. This was a patient that had known coronary artery disease, had a cath, and had an abnormal communication to the PA seen on conventional coronary angiography. And this was just a case of so we have our LAD here, which is tiny, a lot of disease in the proximal LAD. And then you have this funny vessel that's not a named vessel, not a normal vessel that would come off the LAD, not a diagonal or septal perforator, but it comes right up here to the pulmonary artery just above the valve. Now we don't see the jet of contrast going into it, but there was a jet they could see on angiography. And so this was a fistulous connection of the LAD to the PA. And they weren't sure if his symptoms, how much of his symptoms were due to the fistula or how much of the symptoms were due to his coronary artery disease. So there was a debate about what to do. So we were going to bring him back to do a cardiac MR and see what the shunt fraction is to see if there's a lot of shunting going on, in which case they would embolize the fistula. So now we'll move on to the benign coronary arteries. These are anomalies that won't need a referral, but you want to be aware of them because they can be injured incidentally during different types of procedures. They're kind of surgical awareness lesions. And so I'll scroll down here and let people take a look. So if we look, there's no, here's our left coronary cusp. There is no coronary artery coming off of that left cusp. There's no artery running in between the aorta and pulmonary artery. But if we go find our LAD, the artery within the anterior interventricular groove, we can track it back, and you can see it's running in front of the pulmonary artery or RVOT. And so we would call this a prepulmonic. And sometimes it's actually in front of the RVOT, and we still call it prepulmonic, but it's a prepulmonic left main or prepulmonic LAD. And these anomalies are benign. They're not associated with cardiac ischemia or sudden cardiac death. They are important because there's a higher rate of them in tetralogy of Fallot patients. I think about 5% of tetralogy of Fallot patients will have a prepulmonic left main or prepulmonic LAD. And the repair for tetralogy is to do a right ventricular outflow tract patch or transannular patch if they got to go across the annulus of the pulmonary valve. And they can cut through the LAD or left main during that surgery if they're not aware of its presence. So it's a considered surgical awareness lesion, but not in and of itself a problem. But it has does have a higher incidence in tetralogy of flow and can affect the surgical treatment of it. And here you can see the coronals, how we have this nice artery coming in front of the pulmonary. So benign variant, higher incidence in tetralogy of flow, which may complicate repair. All right, here's another benign anomaly. So I magged up this one a little too much, but here you can see the right coronary artery. It's coming off normally from the right cusp. It looks like we have a normal left coming off the left cusp here. There's what we would think would be the left main LAD coming down. But if we look, there's no circ in the left atrioventricular groove. Now we come down here and we do see a circ. So here's the left circumflex. By definition, it's the artery in the left atrioventricular groove. And here we can track it back, and it's got a funny course. So we track it back. It's actually running behind the aortic valve. So here's aortic valve. We can track this circ, runs kind of behind and below it. And it's coming off the right coronary cusp. So this is a retroaortic circumflex, which is just a benign variant. We see it, it's not all that uncommon. And it in and of itself doesn't cause problems, not associated with ischemia or sudden cardiac death. They do like to be aware of these if they're doing TAVRs. If you do a balloon expandable TAVR, you can compress that circ because it's real close to the aortic annulus here. And so they'll put a pressure transducer and make sure they're not occluding the circ when they do the procedure. But other than procedural awareness, it's not in and of itself a problem. And we always do cardiac CTs on our TAVR patients, so it's never kind of an unknown. This was a cool case because they also had a unusual membrane through the middle of the left atrium. And this was also a retroaortic circ with a cor triatriatum sinister. So the membrane through the left atrium was cool. And here's what it looks like on coronals. All right, benign variant may be compressed during surgery or procedures. Here's another case. And we're getting low on time, but I'll go quickly. This is an important one. So I'll scroll through. We see we have our RCA as a normal origin from the right cusp, but we also have this vessel coming off. And this looks a lot like those interarterial ones, which were problematic. But if we look, this comes off and dives down. So I'm scrolling down. And so it goes down into the top of the interventricular septum and then comes out into the epicardial coronary fat to give off the LAD and circumflex. So this is not a truly interarterial one because we're never between the aorta and pulmonary valve. Here you can kind of get a hint that these are pulmonary valve leaflets. So this is all RVOT. This is all RVOT. And so this never runs between the aorta and pulmonary artery. So this, and it runs in the top of the interventricular septum. So this would be a septal or a transseptal course. These are a little bit controversial, but most people agree you don't operate. The surgery is hard, and they tend not to cause ischemia or sudden cardiac death. Here on our coronals, you can see there is no artery between the aorta and pulmonary artery. There's no central dot sign. We come anterior, we can see it coming off this right coronary cusp, diving down to the top of the interventricular septum and then out into the fat. And so they describe this, and if you MIPed it up, they describe a hammock sign where it kind of dives down and then comes back up to get to the normal location for the left coronary artery. Transseptal course, limited treatment options, rarely associated with ventricular arrhythmias and death, and is usually considered to be a benign variant. Here's another companion case, kind of showing the same thing. Here's our left coronary artery coming off the right cusp, but not running in between the aorta and pulmonary artery, but diving down into the top of the septum. And these frequently get confused for interarterial courses. And if you have some question, especially if it's a non-gated study, always get a gated study to prove the difference, because it matters a lot for management. But you can see clearly here, this is diving down into the top of the septum below the pulmonary valves, which are coming up here. So that's PA, this is RVOT. There's no vessel in between the aorta and pulmonary artery. This was a cool case because he also had a retroaortic circumflex. Here you can see the circ coming off of the right cusp going to its normal location. And here we see on the coronals, no central dot sign. And we see it running through the top of the interventricular septum. All right, I think this may be the last coronary case, and we can stop here because we're about at 45 minutes. This is a cool case. I'll show you. Most people aren't aware of this, or there's not much literature on it, but it is out there. So we follow this down, and I want you to focus your attention on the right coronary artery. There's kind of an early bifurcation into the PDA and PLV. But if you look, this branch of the right coronary artery is actually completely inside the right atrium. So a portion of this right coronary artery is surrounded by contrast. It's running within the cavity of the right atrium. And so this is an intracavitary course of the right coronary artery. Now, there's not much literature and there's not much in the radiology literature on these anomalies, but there's several case reports in the EP and cardiovascular surgery literature, because if you have this intracavitary course, it's a benign variant. It doesn't cause ischemia or sudden cardiac death, but if you're doing ablations in the atrium, you can injure this and cause an iatrogenic fistula. And likewise, if you're going to bypass coronary artery, the conventional workup would just be a conventional angiogram. On a conventional angiogram, you cannot tell that this is actually within the cavity, not outside. And so if they want to bypass to this portion, when they go in for surgery to try to bypass to it, they can't find the artery. It's not outside the heart, it's inside the heart. And so it can complicate bypass surgeries, and it can be injured in EP procedures, or anytime you're kind of mucking around in the right atrium, you can actually injure these intracavitary courses. But in and of themselves don't cause a problem. So benign variant, not associated with sudden cardiac death, intramural or intricate. Sometimes they can run within the wall. It can complicate coronary artery bypass surgery and can cause inadvertent disruption if you're doing invasive coronary angiography, pacemaker implantation, or EP procedures. And so the potentially malignant coronary arteries, these are people that will need referrals or the interarterial course. There's some debate about what to do with the right, but they would all need at least a workup for it. ALCAPA and RCAPA are treated, and then coronary artery fistulas, especially if they're large, will be treated. Benign anomalies can be important for surgical or procedural awareness, and these are our prepulmonic, retroaortic, and transseptal courses, as well as the intracavitary course of the RCA. All right, well, we are at about 45 minutes. I'll run through some of these just quickly. This is a anomalous pulmonary venous return. You can see that the pulmonary vein, it looks like it wants to be a left-sided or duplicated SVC, but it goes out into the lung. And so this is a shunt. The pulmonary venous return is not to the left atrium. It actually goes back to the innominate vein, and it's a shunt, and it may be significant, and they may need treatment for it. A lot of times, if it's isolated upper lobe PAP-beer, it's not significant. But if this was the whole left lung and was significant, this patient also had pretty severe asthma. So a lot of mosaic attenuation. And then the other PAP-Beer variant that's kind of important is right upper lobe partial anomalous pulmonary venous return when you see it with a sinus venosus type ASD. And that's what this one is. You can see this is actually a duplicated or left-sided SVC over here going into markedly dilated coronary sinus. But you can see the right heart here is huge, and you wouldn't get a dilated right heart just from a left-sided or duplicated SVC. It's not a shunt. But if we look at our right-sided SVC, you see anomalous pulmonary veins coming in, and then you see this connection between the SVC and left atrium. And so this is a sinus venosus type atrial septal defect. So when you have both the anomalous pulmonary venous return and the atrial septal defect, that frequently is a shunt that'll need to be treated. And then you can obviously see this is a big shunt because of the size of the right heart. And the last case was just a case of scimitar syndrome, which I'm sure y'all are probably most people are familiar with. This was an infant with scimitar syndrome. It can be kind of hard to tell on the axials, but on the coronals, you can see that nice scimitar vein going into the IVC. One important thing about scimitar syndrome people may not recognize is it's frequently associated with anomalous systemic arterial supply. And so we kind of missed the origin of this and got it later delayed. That's why there's this funny gap here. This big vessel was actually coming off the abdominal aorta and going into the right lower lobe. And always, if you're working up a scimitar patient, always look for that anomalous systemic arterial supply because that needs to be fixed. You can't leave systemic pressures going to the lung because it'll cause pulmonary hypertension. So they will embolize those before surgery, or they'll ligate them at surgery, and that's not uncommon to see that. And then this is the typical radiographic case of scimitar syndrome that people are familiar with. Nice big scimitar vein. All right, well, I'm a little over, but not too long. And so that's PAP-Beer. Can be a shunt if the shunt's greater than 1.5 to 1. If the shunt's less than 1.5 to 1, the QPQS ratio, they have a normal life expectancy. If it's over that, they'll need to fix it. If you have a insignificant shunt, but then do a contralateral pneumonectomy, then it will increase the shunt fraction significantly. So it's worth reporting, even if it's just isolated left upper lobe PAP-Beer, because if they do surgery on the right side, then their shunt fraction is going to go up. And the treatment is just reimplant the anomalous vein into the left atrium. All right, and that is it. Open to questions.
Thank you, Dr. Watts, for showing those very classical and illustrative cases, what you can see on routine chest CTs as well. One question I would have is, in the non-contrast scan, we tend to see a lot of coronary calcium on an non-gated routine chest CT. So what are your recommendations when you see calcium, and how do you advise the clinicians how to go about it or the patients?
Well, we report it, and I report it just qualitatively. There's actually, and we've done some work on like these semi-quantitative or ordinal scoring systems where you actually grade the calcium on a visual scale. But there's been some other papers. I know Reggie Munden, he was our former chair, wrote a paper where if you just actually qualitatively grade it mild, moderate to severe, that correlates pretty well with what the actual results would be if you got a calcium score and did the true Agatston score. I don't really give specific management recommendations. I leave that up to the referring clinicians, because some people won't, there's kind of, some people don't really put a lot of stock in the calcium scores, but there's good data on it. I mean, if you have a lot of calcium, you're going to be a much higher rate of events. And so if the clinician wants to work it up, I recommend, if the calcium score is very heavy, then I recommend a MIBI. If I think it's like over 1,000, if I think it's kind of let's say they're a young patient and they have some calcium when they shouldn't have any. If the calcium score, and just my estimation would be like less than 400, I would go to a coronary CTA. With the newer coronary CTAs, we actually can read through the calcium pretty well. So I will do it if I think the calcium score is like 200 or 300. I think it can be more valuable than a MIPI, but generally, if the calcium score, and like in some of our veterans, we'll see the calcium score is obviously over 100. I will, if the calcium score is obviously over 1,000, I'll tell them to just get a MIPI because the CTA is going to be hard. And cardiac valve calcification. Yeah, I do report aortic valvular calcification. And if, because we do a lot of TAVRs, and all the TAVRs, we get the aortic, we actually score the aortic valve calcium. And if it's over 1,000 for women, over 2,000 for men, that correlates well with severe valvular aortic stenosis. So when I'm just reading like a routine non-contrast chest CT or a contrast, if I can see the calcium on the valve well, I'll report it. And if I think it's moderate to severe, I'll recommend an echo if they haven't had one. But yeah, I'll qualitatively report the calcium on the aortic valve. And if I think it's moderate to severe, then I do recommend echo specifically for that.
If they need to be undergoing a coronary or a cardiac CT, would you schedule it on a different day, or would you go ahead and complete the study for a significant anomaly, say suppose an interarterial course or a malignant coronary?
Usually we have to bring them back. If we find just an incidental coronary anomaly, like if we're doing a study for some other reason, we recommend a follow-up coronary CTA, and they usually come back. When we schedule our coronary CTAs, we have to have a nurse. We like to give nitroglycerin and other things, so we don't tend to do it the same day. It's possible if you could and had a nurse, that would be great, but and the scanners are sometimes booked. So yeah, we bring them back. Yeah, I mean, we try to get them back quickly, but it's usually not the same day.
Yeah. Dr. Radharani has a question. Any specific CT protocol for the coronary angio? Dr. Radha, anything in specific you want, or is it a routine coronary?
Oh, I see that. Any specific CT protocol? Well, we have, it depends.
Yeah, please go ahead.
It's kind of scanner specific. You have to adjust the protocols. Like it's, I guess, patient and scanner specific. So generally they'll come in if their heart rate is nice and slow, and their blood pressure can tolerate it. We'll just give them 1 tablet of sublingual nitroglycerin, and then scan them prospectively, because usually when we're doing coronary CTAs, we're not concerned about the function so much. They'll usually have an echo, or there's other ways to get it. So we'll do prospective to keep the dose low, and the image quality is very good. If there's some question about if they want functional information, or like if it's a TAVR, we always do them retrospective. If their heart rate is pretty variable or high, and we can't get it down with beta blockers, or their beta blockers are contraindicated, then we'll do it retrospective, which is can be a substantially higher radiation dose. But yeah, it depends on, for the cardiac CTs, it depends both on the scanner you have and what the patient's like heart rate and blood pressure are. And that's how we protocol them each individually.
Yeah, thank you, Dr. Watts. Any other questions from the audience? Yeah, imaging of vulnerable plaque and clinical significance from Dr. Vijay Bhaskar.
Sure. Well, I'll always look for it. I know it's in CAD-RADS, they have the vulnerable plaque characteristics. If you have spotty calcification, which is kind of a qualitative judgment call, because a lot of times the calcium can look kind of spotty, especially if the image is noisy. But yeah, if you see spotty calcification, low attenuation plaque, which is less than 30 Hounsfield units, if you have what they call the napkin ring sign, where you have a lipid-rich core in the middle and then some calcium in contrast around it, or if you have positive vessel wall remodeling. So those are the 4 signs of vulnerable plaques in CAD-RADS, and to consider them vulnerable, to consider a plaque vulnerable, you have to have at least 2 of those features. Now, we don't really, like in CAD-RADS, it doesn't affect management. The management is guided by the degree of stenosis. There's a lot of research going on, and we do know that people with vulnerable plaque do worse than people without vulnerable plaque. But as of right now, it doesn't really affect clinical management in CAD-RADS, but it does have, I mean, those people are at higher risk. There's some variability to it. Like if you have somebody where you get a really nice contrast bolus, let's say you get the attenuation values of 400 Hounsfield units in the coronary arteries, just that high contrast is going to bleed through any true low attenuation plaque. So there'll be no way to measure anything that's going to be under 30 Hounsfield units when it's close to that very high, dense contrast. So the low attenuation, the plaque attenuation is kind of dependent upon what your bolus is in the arteries, the attenuation of the arteries. So it's not a perfect surrogate. And I've seen what I would sure would be lipid-rich plaques in somebody, and we've gotten a really good bolus, and I put Hounsfield units on it. It's like 60 or 70, not under 30. So I can't call it technically a vulnerable plaque, but I suspect it is. So it's kind of a work in progress. We don't really know. We know that if they do have those, they do worse, but we don't really base management decisions specifically upon the presence or absence of vulnerable plaque characteristics.
Yeah, thank you. Any other questions?